think it is the whole class of agents that's transformative. We have non-chemotherapy-based agents that have clear activity. They're very active. For example, ibrutinib is very active in controlling disease. Most of the patients achieve a partial remission. So there's still disease that's circulating, present, while patients remain on the drug. So it's highly effective at controlling the disease, and this control can last for years. But the disease is still there. So the concept is that, however, we have excellent control of the disease. If we stop the treatments, then patients will progress, and we also worry about development of resistance, like we've seen with other TKIs like Gleevec and the others. And I think in order to appreciate the full impact of that and the propensity to develop mutations and resistance, we haven't had enough follow-up to really have a good concept of how that's going to look in the future. So I think they're transformative. Our work is not done. We still have a lot of issues to address, and I think there still is clearly room for advance in treatments for patients with CLL. I mentioned that it is definitely an advance for patients with a 17p deletion, but if you look at the curves for the relapsed patients with 17p on ibrutinib, the progression-free survival, median progression-free survival is probably about 2.5 years. So those patients are still progressing, and although it will buy them an extended period of time, they're still what I would consider high risk, and we still need to move forward with other treatment modalities and treatment approaches for those patients as well as others, because as I mentioned, these are agents that we're going to have to keep patients on, and they don't have an insignificant amount of disease while they're on the treatments. That is, they still have a fair amount of circulating leukemia cells, there's disease in their bone marrow, and we worry about resistance and what that's going to look like in the longer term follow-up.